Hello, everyone, and welcome back to the Med Voice podcast. Today, we have a very special guest, Dr. Laura Vater. She is an oncologist, but not only that, she is a distinguished writer, a TEDx speaker, and advocate for the well-being of both clinicians and patients. How are you doing today, Dr. Vater?
Well, first of all, thank you so much for having me here. I'm thrilled to be here and I love the work that you're doing. So thank you for inviting me. I'm doing well. I'm an oncologist, so was just finishing up my clinic today. And so and I'm also a mom. So it's like balancing those things, but I'm so thrilled to get to be here with you today. How are you doing?
We're doing really well. Thank you so much for coming on. We know you're so busy, so thank you so much. Just to start off, we wanted to ask you if you could tell us and our audience a little bit more about yourself and expand more on your practice and everything else you do.
Sure. So I am a gastrointestinal oncologist, which means I take care of patients that have cancers of the gut. So colorectal cancer, liver cancer, pancreatic cancer. Those are the primary cancers that I treat. But my background, so like many of you, it feels like it's not that long ago that I was, an undergrad and then into medical school. For me, my path through that was that I did a science major. I was a biology major, which now I realize you don't have to do. And actually, if you have an interest in another area, that's, sometimes even better. But then I ended up doing a minor in poverty studies and became very interested in public health and the social determinants of health and prevention. So I did 3 gap years. So for those of you who aren't familiar with that term, that means the time you take between your undergrad degree and your medical school. So I took 3 gap years. I did a year of global health work in Haiti as a teacher and got to work with some of the people there doing some public health initiatives. And then I did a 2-year master's in public health program, again, because very interested in public health and global health and prevention and social justice. And then it kind of confirmed to me as well that I wanted the credibility of being a physician. I wanted to see patients every day, and I wanted to be very, very much involved in their lives. And then I did, of course, medical school, and I did mine at the Indiana University School of Medicine, and then I did an internal medicine residency at Indiana University, and then a fellowship in oncology also here at Indiana University. I'm from Indiana, which, I know there's many people here who are from Canada. That's, kind of in the Midwest, not too far from Chicago. My family's here, and we have such a strong program here at IU within internal medicine and oncology. And I have some incredible mentors and really wanted to stay. And I had a child when I was a medical student in my 4th year. I've also come to love this field of narrative medicine, which is really deep reading and writing and understanding of patient stories and narratives to try to improve our ability to be present and to connect with patients. And so through this, I've published some narrative medicine essays. I'm part of the Pegasus Physician Writers at Stanford. I'm working on a novel, lots of other things that I also do some speaking as well. I know that we mentioned that. So lots of things that I never envisioned where I would be, when I was back in my undergrad years. And that's the amazing thing about your career trajectory is that things evolve and change. And if you really pursue the things that matter to you and are of interest to you, then you're going to have a really meaningful and fulfilling career.
Right, that's a very interesting medical journey, and you have a lot on your plate, obviously. And one thing that obviously stands out is that you're an oncologist. Now, we've heard a lot of stories about oncologists, so we just want to know what got you into oncology in the first place.
It's been lots of factors that have confirmed that this is the right career for me. It really started when I was in high school. I'm from a small town, and I had this coach named Kim, and she was my volleyball coach when I was a kid. And she never married, she never had kids of her own, but she actually was this almost like this family friend and this mentor to me for many years. And she was diagnosed with stage 4 colon cancer when she was 40. When she was in her early 40s, very, very young. And at that time, she knew of my interest in science and in medicine. And she said, why don't we arrange for you to observe my surgery and for you to get to see some of these elements of my chemotherapy and my care? And so I got that opportunity as a teenager, which was, looking back, almost unheard of. And then just very close connection with her. She ended up passing away when I was a sophomore in college. And just lots and lots of factors there. And then when I had a mentor in oncology when I was doing my public health degree. I had a mentor who was a palliative care physician who also was doing palliative care work within oncology. So again, I got to work with patients with cancer. I got to work on cancer communication research studies. And then it was, I was like all of us, I think when you're in medical school, it's really good to be open-minded. Could I see myself being an ENT surgeon? Could I see myself doing pediatrics? Could I be a neurologist? I think that going into those you're in your medical school years, your third and fourth year are those clinical years. The first two are very much learning in the books. The second two are typically every month you're doing something different. So I was trying to be very open-minded, and I was. There were lots of things that I could see myself being happy doing. That's true. I think we could probably do lots of different things, but for me, it kept being working with patients with cancer. And so that just, again, when I was just very meaningful interactions. And oncology is a unique field because I see my patients every 2 to 3 weeks, sometimes every 4 weeks when they're getting chemotherapy, sometimes for years. So I am their doctor that is helping them navigate through this really difficult thing. And again, the types of cancer that I treat, a lot of my patients have advanced disease or aggressive cancers. And so I am that person that gets to guide them through their treatment. I get to care for them. I often get to do a lot of palliative care. I get to support them at the end of their life. And it's a very, very meaningful, for me, a very, very meaningful job and a privilege to get to do that work. And people say to me, oh, isn't it so sad? I could never do oncology. It's just like the most depressing thing. But it's really interesting to me how much my patients, they have this perspective on life where they're going to make the most of the time that they have, and that the relationships matter, and that these things matter. And so they come in and they tell me stories and jokes, and we laugh and we celebrate the wins, and we help them to feel as well as possible. And there's a lot of joy in the work that I get to do, and a lot of meaning. And so it's just this, and oncology is this field where I have this opportunity to be in clinic. I also have a lot of support. I don't have, my balance of my work and my life and being able to be with my family. It's also just this wonderful balance of getting to care for my patients, but also I don't have that many things where I'm getting emergencies or I have to go in emergently or I have to work all these extra hours. It's a really nice balance if I care for my patients well and I am there for them, but I also have this opportunity to be present with the other people in my life that matter too.
So going off of this idea of work-life balance and the fact that you have so many things on your plate at the moment, when it comes to being an oncologist and actually managing all those different things, how do you find that you're able to sort of accomplish all the things that you have set out throughout the day while also providing that high quality care to your patients as an oncologist?
Yeah, thankfully, oncology is very much a team effort. We have conferences called tumor boards where we get together with surgeons and radiation oncologists and radiologists and interventional radiologists and pathologists. We all get together as a team, and then we get to come up with a plan together. And so it's not just the burden on me of what's going to be the best care for this patient. It's also what does the surgeon think and what is this other medical oncologist. So it's a collaborative field, which is wonderful. And then in my clinic, my day-to-day clinic, I have a nurse, a registered nurse who helps me counsel patients and do patient consents and helps answer message. And then I have a dietitian and I have a social worker and I have a pharmacist and I have this it's really, this is true for all of medicine, but particularly oncology, is that it's a team approach. And I rely heavily on those people to work to the highest level of their degree so that I can work to the highest level of my degree and make these complex decisions for patients and help guide them and counsel them and change and tweak medicines and all of these things. Of course, there's days that are busier than others. And it's all about, finding support where you need it, figuring out what is going to be a reasonable workload for you. And then also, it's important for all of us, wherever we are, to set boundaries. What are the things we're going to say yes to in our lives? And what are the things that we can say no or not yet? And I think that those things are really, really important. I work in academic medicine, which means that I I get to teach medical students and residents and fellows, and I also have opportunities to work at a university here at Indiana University. And I am creating a writing, with my colleagues, we're creating a narrative medicine program here called Writing for Wellness. And I'm going to create a program for young adults, essentially early onset colorectal and other GI cancers. And I get to take the time. I have extra time in the work that I do. I have 3 days of clinic and I work in the hospital and I'm still full time. And I get to do all these other things that are meaningful to me. And so I feel like for each of us, especially in a medical career, we get to choose that. We get to choose, how many days a week do we have? How much call do we have? Do we want, are other things fulfilling to us? Is teaching important to us? What are our hobbies and how can we make the practice of medicine better because of we are all diverse people in our own ways with different interests. And I think it's really about figuring out what matters to you and then how and what's of interest to you. And then how can you pull that into your days? I think for all of us, right? It's easy to say, well, my mentor likes X, Y, or Z and thinks I should be in the lab doing bench science research, right? But maybe you do love bench science research, but maybe you also love public health, or maybe you also love this other thing. And can you make that part of your career? I think that figuring out who we really are and what we really enjoy and how can we spend our time clinically adding some of those elements to our life. And it doesn't necessarily for me feel like, I'm doing all these separate scattered things. It feels very united in this whole of my goal of trying to make medicine more human for patients, but also for us as clinicians.
Yeah, I feel like everything you said resonates with, I would say, all of us a lot, because I feel like there's so many things going on in life, and if they aren't things that recharge you and make you happy, you're going to burn out pretty fast, and it's going to be really difficult to keep going when you're not enjoying stuff. And also, as a medical student coming in, I've realized how important the interdisciplinary team is and how many people there are supporting doctors. It's truly amazing the work that they do. And the next question I wanted to ask you is kind of related to something you mentioned earlier. So oncology is a very impactful field, and you told us about the meaning that you get from it. However, that aspect of sadness, because especially for you, as you said, there are many patients with advanced disease, that sadness still is there, and you still have to deal with that in some way, one way or another. So I wanted to ask you how you cope with that and any strategies that you have for students that are coming up, because I feel like people who experience this for the first time, it can be something that's really difficult. So if you have any strategies, that would really help.
Yep, that's a very important question and one that we do not talk about enough in medical training. All of us, whether you are a cardiologist or a trauma surgeon or an oncologist or a pediatrician, even a radiologist or an ER physician, we all are going to witness trauma and illness and suffering and death. I mean, that is the field that we're choosing because we choose to be with humans and help them in those moments. But the truth is that there's no way we can walk through this and witness these things and not be affected in some way. And yet we don't really talk about that, how those things really affect us. And the truth is that we all need to think about what are those strategies. We all need strategies, whether that's to face the next shift or the next hour or the next year of our lives. We need healthy ways to be able to process and cope with those things that we witness. And in training, you're going to experience this, right? There's a lot of dark humor. There's a lot of just brushing it off like it's nothing. A patient you're giving CPR to one patient and they pass, and then boom, you're expected to go admit another patient. All of these things have happened to me, especially in the ICU. But the truth is that whether that is the next day or whether that is even the next week, we have to find ways to process and cope. For me, when I was a medical student, that is really why I started writing. It started out as journaling. I was a pregnant medical student in my third year on my OB-GYN rotation, and I was on high risk, maternal fetal medicine for these mothers that were at very high risk. And when I was 23 weeks pregnant, I witnessed the stillbirth of a child that was 23 weeks of gestation. So this family essentially was going through this ritual of loss after losing their child, and at the same moment that I was at the exact same stage in my pregnancy. And as a medical student, you kind of hang back and you are a passive observer. You witness, you stay quiet, you just, are respectful, and those are all the appropriate things to do. And when I walked out, it was 3 o'clock, 2 or 3 o'clock in the morning in the middle of February. And I walked out to the parking lot, and it just was this overwhelming sense of sadness, for grief for this family. What did they have a crib in their house, and what color had they painted the nursery, and all of these things that I was thinking, and also this worry of loss for my own child. And so what do I do with this was my question. How do I process through this? And so I really came to writing. I think that back then I was very worried that if I, for some reason, had a therapist, that would somehow, hurt my chances of matching. I think that there's a lot of stigma about, talking about grief, or even, any mental health condition in medical school. But the truth is that half of us in medical school would experience anxiety, more than a third experience depression, some have thoughts of suicide. I think that it's in part because of overwork and sleep deprivation and the pressure to perform, but it's also, there's this other component, right, of grief and loss and how to process. So I really think that anyone in the medical field, whether you're a medical student, you're a nurse, you're a respiratory therapist, a physician, we would all benefit from having counseling, having a therapist, almost like as prevention. And I do that now. I have a therapist that I meet with once a month. And sometimes we're not really talking about much. We're talking about parenting, or we're talking about marriage, or we're talking about, hope, whatever, but oftentimes when I lose a patient, especially if it's a really devastating loss, I have that. It's like an extra layer of support that's just there, that I can, and sometimes you'll talk about things and things will just come out that you didn't realize were kind of building up in you. So I think that having mental health support is really key. You can do that outside of your hospital network. You can do that anonymously. You can do that in all sorts of ways. So just putting that, for your listeners, putting that in the back of your mind as a potential resource. Other things that can really help are, debriefing the people that were involved in that, caring for that same patient in that moment, of just saying, oh, that was really hard, or taking a moment, or if there was uncertainty about what happened, or there was medical error, there was something like that, just taking time to process and cope through that. And there are also people in the hospital, like chaplains or social workers or other team members, that really like to serve in that role of caring for the carers. So just keep all those things in mind. And then checking in with your support system, the people in your life that have helped you to get where you are. Think about who those people are. Maybe it's your family, maybe it's your friends, maybe it's your classmates. Those are the same people that you should think about reaching out to if you're facing, and not as a sign of weakness, but of that we all will experience this. And if your friend is reaching out to you, being there for them and saying, hey, me too, this happened. And just normalizing that this is not normal, that we do not live and work in a normal work environment. It's hard to lose patients. And so making sure that you have things set up in your life to process and cope. Other things that help me, physical activity and being outside in nature, music and prayer. And I think that there's all sorts of ways that we can also help with our mental and physical health to cope through those things. But really having a mental health structure of support, I think, is really key.
Yeah, for sure. I think like there's a lot of different hidden issues in the field of medicine, because doctors or even healthcare professionals are seen as the healers, not the ones to be healed. And usually all of these issues go hidden and not noticed. And I actually read one of your tweets, and this was also on Instagram. I just want to read it, and I just want you to talk about it because I think it's very important to mention. But you wrote, we as a body of physicians must take a hard look at the data on sleep and do away with the archaic model of medical training that sleep deprived and dehumanizes young doctors. So I just want to get your opinion, just further elaboration on this idea of sleep deprivation and how there's a lot of medical students and residents and doctors that are suffering through this. And if you have any personal experiences or stories, that would be amazing.
Yep. So for those of you who are listening that may not be aware, doctors in their training and all the way through their life as medical practitioners, they experience sleep deprivation. This may be a 28-hour shift that's still allowed among residents, so interns and residents. You may be on what's called home call, where you are on a 72 or 100-hour period of time where you could be called anytime within that window, day or night, and have to go into the hospital. Oftentimes what happens is you may get called, especially on a busy weekend. You may get called every 20 or 30 minutes all day and all night. So you're working sometimes 70 hours or 100 hours straight. This happens in training, not just for doctors in practice, but for doctors who are in training. And what also happens is that while we have made some progress nationally where we've kind of limited those shifts to 28 hours or the total weekly numbers to 80 hours per week, what happens is that there's a lot of loopholes to sleep deprived trainees, especially home call being one of them. The other one being that unfortunately, many residents and fellows are taught to just simply lie on their time cards. So they may work 90 hours or 100 hours a week, especially in surgical fields. I've had hundreds and hundreds of residents reach out to me and say, yep, if I go over 80 hours per week, they email me and say, did you make a mistake? Let me fix it for you. Or you went over 80 hours per week. You have to sit through this 2-hour training on efficiency, how to be more efficient. I think that what happens is that when we are sleep deprived, it's like being legally drunk. So if you are awake for 24 hours straight, it's like being intoxicated. And they've proven that through research. What also happens is that, so you're not able to think as well, right? Your physical coordination is lower. The risk to patients is higher. So more medical errors, patient safety issues happen. But what also happens is that you're at a huge risk to your physical and mental health, right? With sleep deprivation, you're at higher risk for all sorts of heart problems and diabetes and in the long term, Alzheimer's. But you also have an increased risk of anxiety, depression, and suicide. And now we're further learning that when you're sleep deprived, the parts of your brain that process empathy, where you feel empathy, actually don't work. Tired doctors have lower empathy for patients, and we've proven this through research. So we have all of these reasons why we shouldn't sleep deprive doctors. It's not just about patient safety, and it's not just about empathy and compassion, but it's also about looking at a person, a young doctor, or a doctor throughout their career and saying, we don't care about their physical or mental health, and we're going to continue to sleep deprive them. And that to me is very unethical. And now that we are collecting this huge body of data on sleep, we need to take a hard look at how we treat our residents and our fellows and our interns. And we really need to make it a priority to protect their sleep. And the reason I'm so passionate about this is because I didn't know really anything about this before I was an intern and a resident myself. And then I started to be sleep deprived. And when I was sleep deprived on 28 or 30-hour shifts, which are just normal, very, very, very normal across programs. And thankfully, my internal medicine program has completely done away with those, which is incredible. But I would experience brain fog, trying to keep things straight. And we know that through research that our brains do not work as well. I would also, have, close calls when I was driving. I thankfully did not get in an accident, but we have, unfortunately, many people die each year in fatigue-related accidents that are in medical training. And I also noticed a decline in my mental health. I noticed that when I was sleep deprived, that I was having a decline in my mental health. And then I started learning about this, and I started just in small ways raising my voice. Does anyone else feel the same way? This was back when I didn't use my real name on social media, and I was very hesitant because I really care about my leaders of my programs, and I wanted to be professional, and I wanted to be respectful. And thankfully, with data, with creating relationships with my leaders, with bringing them data, with talking about real experiences, we've been able, across the country, to make meaningful change at my program, and other people have been able to do the same. Because I really do think that there are good people in medical education who care about learners, and it's really about having a conversation about this. Does this still make sense? In my mind, I don't think it does. It often comes down to a staffing issue. Do we have enough people to cover the hospital, to be there, to be available for patients? So it really comes down to, do we need to expand residency slots? Do we need to train more doctors? Do we need to hire more doctors? Do we need to try to retain the doctors we have who are leaving the field of medicine because of burnout and overwork and sleep deprivation? It really comes down to caring for the carers so that they can have a long, meaningful career, and they can also have the health that they strive so hard to give to other people.
That's definitely a very interesting topic to delve into. Even something that I found really interesting that you said that I personally did not know beforehand is that sleep deprived individuals have less empathy. That's something that's very interesting, and I'm sure a lot of you in our audience maybe have not known that statistic or that fact as well. And even in my own experience as a learner, I've had several moments where I've unfortunately been sleep deprived, and I've noticed these effects on mental health, on terms of brain fog, even reduced performance. So I can't imagine that in a stressful environment like being in medicine, in the healthcare field, the detrimental impact this can have not only on yourself as a doctor, but for your patients as well. And this sort of brings me into the next point that I wanted to make, which is given the fact that we have these burnout problems, these effects of sleep deprivation, what are some ways that you think, given your experience and knowledge, that we can create a more safer environment for not just our medical trainees, but just people practicing in the medical field in general?
Yes. So I still believe that practicing medicine is the most meaningful profession. I still enjoy waking up every day and going to my job and taking care of real people that are dealing with extremely hard things. It still gives me so much meaning to do that work, and it feels like a privilege. But I know personally, because I have so many people that are experiencing this, who are experiencing not being able to be present with their patients, not being able to provide thorough care, not being able to be the doctor that they want to be. And oftentimes that's because most doctors, many doctors, I should say, some of the big issues they're facing is that they're asked to do more and more work in less and less time. They're asked to see medicine is becoming increasingly complex. Patients have more diagnoses and there are more things we can do for them. And it's really hard to do all of those same things in a 15-minute window or a 20-minute window, especially in clinic. And so what happens is that you get these incredibly kind, compassionate, altruistic people who have all this incredible training, who are told, okay, you have to move faster. You have to see more patients. And what happens is that they find themselves in this hurried sickness, right? Where they're just find themselves rushing from one thing to another, not being able to be the doctor that they might want to be. The pandemic kind of amplified this because of just the need, but most physicians experience this in some capacity, and that's a huge contributor to burnout. Some of this is related to, again, time crunches. A lot of it is due to documentation demands of what is required of that doctor. And then again, sleep deprivation contributes to it. Lack of autonomy in their work and control over what they do each day, and then lack of kind of extra support. Right. So if you have, for me, I'm so great. I mean, these are really, to me, really, really huge keys of burnout and protection from burnout is, do you have support so that when your inbox is filling up with messages from patients, you have someone that helps you with that and triages that. I have a nurse that helps me with that. If you have a patient that needs a refill, or you have a patient that has a question, or a patient needs counseling about X, Y, or Z, and there's someone else on your team that's able to do that, that frees you up to be able to do other things. And so some of my colleagues who work in primary care in particular, what they find, they just came out with a study, right, that if a primary care physician was to do everything they needed to do in one day for their patients, prevention and chronic care and acute care and inbox management and refills and all this, it would take them 26.7 hours per day. Right, 26.7 hours, right? They are a human being. They only have 24 hours a day, and they also need to sleep and take care of their families and take care of their health. And so I think that that's just a really interesting study, and that we need to look at as a whole in healthcare, is that we have incredibly kind and altruistic and smart people like you who are going into this field. And what we need to do is protect their ability to do this work. We need to make sure that they have reasonable workloads, that they have adequate support, and that we truly care about their health, both their mental health and physical health. And that includes making sure they have access. I believe everyone in healthcare should have immediate and accessible access to mental health support just built into their career. So I think that those are some strategies. I'll just briefly, for residents in training, for doctors who are, interns and residents and fellows, really a priority on their sleep, on their learning, and really on not trying to take away things that are not actually contributing to their wellness, right? Let's do a module or let's do X, Y, or Z, really making sure they have enough time off, enough time with their families, time to sleep, time to exercise, time to eat well. Really, it's really about how can we give them a reasonable workload and also truly find ways to protect their health. And I think we as a society need to take a deeper look at how do we support our healthcare workers with extra additional support that they need in their clinics or in the hospital, but also do we see them as whole human beings? Do we see them as valuable people that we want to hold on to so that they don't leave the field of medicine? And unfortunately, many clinicians are finding themselves in a place where they love taking care of patients and they love practicing medicine, but the environment in which they find themselves in is not one that's conducive to their health. And so they're finding something else. And to me, that is incredibly tragic.
Mm-hmm. And that's also true that you just talked about. I would say here, especially in Toronto, there's a huge problem with finding family physicians because there's such a big shortage here. So it's almost impossible to get a family doctor here. And even if you somehow do have one, they probably won't spend more than 15 minutes at max with you. Most of the times it's just a phone call. So I think our viewers will definitely resonate with that. And that's something I feel like is an issue in the US and in Canada, not just with general practitioners and family physicians, but also with so many of these other specialties. And I saw one of your posts, you were talking about how Congress just approved more residency spots in like a really long time, but it's still not enough and they need to do more. What do you think about the doctor shortage that it's happening honestly all around the world, whether that's with the NHS in the UK or Canada or the US?
It's a very complex problem, and there's a lot of factors. Because as I'm learning more about this, I'm actually learning that there are residency slots that go unfilled. So there are some competitive areas, but often the ones that there. So while we do have slots, a lot of medical students are not wanting to go into primary care. And it's those primary care slots, particularly in underserved and rural areas, where residents are not necessarily wanting to match. So I think there's really two problems, is that we're facing a critical physician shortage in the United States. It's predicted that by, in 10 years, we're going to be short more than 100,000 physicians as our population ages. So we're already facing a physician shortage and it's going to get worse. And at the same time, we're facing a critical shortage of critical shortage of primary care, but also kind of lack of funding and lack of support for prevention, public health, and primary care. So I will speak from personal experience. I have a number of colleagues who work in primary care, who love their patients, who are dedicated to their patient population, who say, okay, well, you want 30 or 40 minutes to take care of this patient that has 10 chronic problems and has all these things. Well, we're going to shorten that to 20 minutes. And it's really, really hard. It's really, really hard to be that physician, put in that position ethically of, if I need this much time to be the doctor I want to be, and I only have half that time, then I'm just not going to be the empathetic, thorough doctor that I want to be. I'm going to be rushing. And and that not only causes you stress, but it also causes you some moral angst of I want to be this and I can't be. And so it really needs to be, how do we incentivize primary care? How do we improve public health and prevention, which improves our society as a whole? So I think that's one factor, is we really need to continue to incentivize young doctors to go into primary care, compensate them well, and adequately support them. Because I think there are many, many who would love primary care if they had the support and the compensation that they truly deserve. The other component of this is that we have a lot of medical students, and medical schools have increased the number of medical students. But like you had mentioned in your question, the number of residency slots has not increased at the same rate. And thankfully, Congress has approved. And this, for some people that are listening, you're like, how in the world does Congress have to be involved with residency slots? But it's actually these slots, these training slots, these residency slots are funded through Medicare. So in order to have more of them, some individual hospitals can fund their own too, but most of these are funded through Congress has to approve the funding for these slots. And so some people in medicine say, whoa, we don't want more doctors, because if we have more doctors, less work. And if there's less work, there's less compensation. And so, you're going to hear people all across the spectrum of what they believe. My belief is that we are facing a dire physician shortage. It's across specialties, but it's primarily very, very strong within primary care, within underserved areas. So we need to find ways as a society to highly value people practicing, who practice with our own professional respect, because I believe that's still the hardest job. That's the hardest job, is to be in that position, to have, to really talk about the meaning that comes with caring for someone, sometimes from the moment they're born until the moment they die, right? Or caring for them for 30 or 40 years, just that relationship and that beauty that comes from that meaningful relationship. So incentivizing primary care, but also continuing to advocate for continued expansion of residency slots. And to me, it's not just incentivizing people to go into these fields and increasing the slots. It's also about retaining our physicians, retaining them in the field, because we could continue to increase medical slots and increase residency slots. But if we still continue to treat physicians as if they are expendable and replaceable and that their health is not valued, then unfortunately people that have a way out are going to leave. And so we're not retaining them. And so that's a whole other issue. But I think that when we really say, physicians are whole human beings who deserve to have their health protected, who deserve reasonable workloads. And we need to do everything we can to try to limit their burdens on documentation and, communication with insurance companies, at least here in the United States, and prior authorizations and all these other things that take up our time. And then really, really, really saying, how can we support them so that they have reasonable hours that they're working and also a life outside of medicine.
Right, it's a very complicated process, and I believe that everyone needs to be involved in this, and everyone needs to step up for, change to be made. And it's good that, you're using the platform that you have to make change now and to raise awareness about these hidden issues. But switching gears back to your medical career, I'm sure the viewers want to know just a typical day in the life of an oncologist. So if you could just go through a quick day in the life, what time you wake up, what time you go to the hospital, and stuff like that.
Yep. So I will tell you that I'm a little bit unique because I have a young child and I'm a writer. So I am usually awake. My alarm goes off at 5 a.m. And if you would have said that to me when I was in medical school, I'd be like, oh my gosh, that sounds awful. But I'm in the 5 a.m. club now. I wake up early and I write. I write for about 2 hours. And then I help get my husband, thankfully, does most of the things with our daughter. He gets her up, he gets her breakfast, he gets her on the bus, he gets her, so I still have time to get ready for work. My typical work day starts with a conference virtually, a tumor board conference where we all get together and get to talk about patients. So I usually do that from home. Sometimes we do that, when I'm physically at work in the morning, but it's usually about 7:30 to 8:30 in the morning is a conference where I get to meet with my colleagues. We get to talk about complex cases. We get to look at scans, and it's virtual now, which is great. So sometimes, if I'm not presenting patients, I can do that and listen in when I'm driving just for my own education, because it's just this incredibly beneficial thing to work with surgeons and this whole team of doctors coming up with a care plan. My clinic starts around 8:30 or 9 o'clock. I typically have 30 minutes to see a patient who's a follow-up patient, or 60 minutes for a new patient. And so let's say I'm seeing a brand new patient. I get to meet them. I get to meet their family. Usually they bring in all their loved ones. They have people on the phone. We talk through, what is this diagnosis? What does this mean? And what is our plan? That plan has typically already been formulated by a team myself with another team. Sometimes it's that I'm just getting to know them. And then it says, okay, now I say, okay, now I'm going to bring this to my team. So most of our decisions are made in a team setting. When I see a follow-up patient, I get to, they come in, they get their labs done. I get to see them face to face. I get to, how was your weekend and how's your family doing and how are you feeling? And then I get to, if something's not going well with their chemotherapy, then I get to add a medicine or subtract one or try different things. And that's the great thing about oncology is most of my patients are feeling pretty well most of the time. And my goal is to help them to feel as well as possible for as long as possible. And so I see patients, throughout the day, sometimes new, sometimes follow up. I will tell you that I know my patients. I can see who's coming into my clinic, and I typically already know so much about them. And I love getting to spend time getting to know them as people. And for those of you who are nearing medical school or in medical school, I will tell you that is going to be the most meaningful part of your job. That's going to get you out of bed in the morning. That's when you say, I know who this person is I know them as a human being beyond their diagnosis. I know what matters to them. And patients will tell, like today, I had a patient tell me a joke, and I like just like getting to know people and multifaceted components and getting to know their family. It's just such a meaningful thing of getting to sit with them and help them to feel better and connect with them. And so I do that. My last patient is typically around 3:30 or 4 o'clock. I'm typically out of the office by 4 o'clock or 5. I try to, for me personally, I try to do my notes not in the room with them, but kind of right after I've seen them, and I can dictate into my phone and kind of get things done. I typically, will do orders and things like that, ordering chemotherapy when I'm, just out of the room with them. And so I try to get all of my kind of checking my boxes and things so that I don't have a lot of work that builds up at the end of the day. That's just been something for me that's been really helpful. And then I drive home, and then my daughter, she's really involved. Right now she's doing piano and she's doing dance. She just got finished with basketball. And so she has some type of activity. So if she has some type of activity, I sometimes am able to make it. Usually we'll go as a family. Maybe we'll grab dinner after. Sometimes we're just going to go take our dog for a walk and go for a bike ride in the evening. And then my daughter and I have a couple of hours in the evening where sometimes we read, sometimes we watch a show together, sometimes we're just lounging or, we're out in the backyard. And so this is funny, right? I never thought I'd be this person. I'm usually asleep by about 9 o'clock because my daughter is asleep early and I'm waking up early. And so it's just this ritual that we get to do together. So that's what a typical day looks like. Sometimes I'm in the hospital, which means I'm the doctor on service. That happens about 4 times a year, where I do about 4 weeks a year, and then where I work the weekend. So I'm only on call, getting calls throughout the evening or weekend only on those weeks. So it's really not very much, about 4 weeks for the whole year. I don't get that many calls at night. Sometimes they're about patients, across the state that want to come to our hospital. But in those moments, I have clinic and I get to see patients in the hospital that have a new diagnosis of cancer or have something worsening like pain or nausea or something's, their bowels are obstructed. And so most of the work I do is in the clinic, but I also have this opportunity to meet patients with all types of cancer when I serve in the hospital. So for me, it's a very good work-life balance. Like I said, I have 3 clinical days a week. I have 2 days where I get to do academic stuff, do meetings and create projects and do some research and those types of things. So for me, it's a very good balance and very meaningful. And I get to work from home those 2 days where I'm home, at least for now. So it's been kind of nice that I get to have this kind of hybrid model where I'm still full-time, but I get to teach medical students, residents, and fellows, be in the hospital, be in the clinic, have a meaningful career, but also get to be present for my family.
That's absolutely wonderful. It's amazing to hear that you have this amazing balance between the dedication and service you provide on the job as well as to your family. And I think one part that I really want to highlight is this part where you talked about where, you get to learn more about patients, you get to hear the jokes they make in the clinic and the hospital. And I think that that's what narrative medicine is all about, right? It's all about learning about the patient beyond their medical condition for who they really are. And I think that's really what your narrative writing is all about too. And I guess building off on that, you've grown your social media platform to a very, very large amount, over 100K followers, and that's something that's very commendable. And I'd just like to highlight exactly how you've been able to grow it, as well as how your narrative writing, as well as just your social media, has helped you spread your messages related to advocacy.
Yeah, well, thank you. I really appreciate that. I never thought that I was gonna when I was in medical school, I was like, oh, I can't have social media. Someone's going to see it and be like, oh, that's unprofessional, right? So there's a long time in my life where I was just not talking in public spaces, I will say. For a long time, I didn't use my real name. And then it really became a source of community for me. There were other medical school moms. There were other people who were thinking and talking about the well-being of residents and fellows and medical students. There were people that talked about bullying culture, and there were people that talked about discrimination of women, and there were people that talked about all these things, right? And now I have this narrative medicine community. I have this community of physicians who are being really active in the mental health space. I feel like being on social media in ways that I never could understand have helped me to connect. It's how I've connected with the physicians at Stanford, and I'm part of their Pegasus Physician Writers Group. It's how I got to give a TEDx talk about how exhaustion kills compassion, which is going to be out at the end of April on YouTube. And then I get to give the commencement address at the University of Minnesota Medical School this year. And so, I mean, all these cool things that I just never would have imagined. And I will tell you, it's all about connecting with people and just slowly, it's like a collective, I call it like a collective raising of voices, where we can only do so much as individual people, but it's really about just slight changing of someone's perception of, oh, maybe we shouldn't continue to sleep deprive our interns in this way, or maybe we should be respectful of our medical students and be very careful to make sure that they feel included and valued, and that the language we're using is not bullying them, or yes, this patient is a whole human being, and right. And so I think that really my goal through the things, thankfully, through the platforms I've been able to develop and through my writing, really is seeing patients as whole human beings, but also seeing the clinician, seeing the caregiver, the healer as a complete person, that their health matters just as much as the patients that we're trying to care for.
Yeah, and with that message, I think that brings us to the end of this podcast. Everything you've said to us has really taught us so much about the medical field, especially about oncology. And I feel like a lot of our viewers will be attracted to this field now because of all the exposure that you're giving to it. And I'd just like to say thank you for all the work that you're doing, spreading advocacy about patients and about residents, because these populations aren't really populations that have much advocacy around them. So I think it's really commendable what you do. And I'd like to thank you from all three of us from the bottom of our heart. And thank you so much for making the time to come on.
It was an honor to be invited, and you're doing such incredible work. Thank you again.